Good afternoon, everyone. I'm Dr. Pratik Tambe, Chairperson for the AMOG's Endocrinology Committee. A warm welcome to all the respected dignitaries, faculty who assembled for today's event. Today's program is centered around key issues in obstetrics and gynecology. A warm welcome to everyone and also to the audience who's joined us throughout the length and breadth of Maharashtra and the rest of India as well. Today being a holiday, we typically didn't want to conduct an academic event on a holiday, but there are very few dates that are available in this month of March. So, apologies and thank you so much, all of you, for joining us. We have two fantastic speakers, Dr. Sagar Kataria, who is the Zonal Coordinator of AMOGS, and Dr. Chaitanya Shembekar, who is the Chair for the AMOGS Infertility Committee, and Sir is also contesting for the post of Librarian of the Maharashtra chapter of ISAR. We wish him well in that endeavor and we look forward to seeing him progress much more in whichever chosen organization he chooses to represent. He was also a member of my endocrinology committee when I was Foxy chairperson last year, and it will be wonderful to hear from two wonderful stalwarts, pride of Maharashtra, I would say, for being here. Thank you so much, taking out time from your busy schedule. Let me start by offering my gratitude to our president, Dr. Nandita Palchetkar, who's the current president of AMOGS, the immediate past president of Foxy. She's been a past president of IAG and the Mumbai Society in the past, always there as a guiding light for us juniors, always supporting and promoting, encouraging us in all our academic endeavors. Thank you so much, ma'am, for your blessings. Next slide, please. I'd also like to express my gratitude to Dr. Arun Nayak, who is the Secretary of AMOGS, also a past president of the Mumbai OBGYN Society, similarly, always there with us for academic activities. It's lovely to have the blessings from our office bearers for all of our events. Thank you so much. At this stage, I should also express my gratitude to the ICOG chairperson, Dr. Mandakini Megh, and the secretary of ICOG, Dr. Parag Biniwale, both of whom have given us ICOG credit points for all our events so far since the past 1 year, including today's event, which is accredited with one ICOG credit point. We have three eminent stalwarts as chairpersons who are here to conduct today's proceedings. And the first of these, next slide, please, Shriman. Yes, is Dr. Rajendra Singh Pardeshi, sir. Sir is the Vice President of AMOGS, and with Dr. Nandita Palchetkar, last year he was the Vice President of Foxy as well. He has an unparalleled record of 6 times Best Paper Awards at AICOG conferences, which is probably unbreakable, I would say, in the modern era. And he's a very distinguished gentleman, invited to several events, both nationally as well as internationally. We always look to him for support and guidance, and every time, whenever I request him, he's always there to represent AMOGS at all of our events. Thank you so much, sir, for taking time out and joining us today. We are also privileged to have with us Dr. Charmila, who was the chairperson of the Clinical Research Committee of Foxy from 2016 to 18. She's also been the awardee for the Best Committee Award of Foxy for her tenure in Foxy as the head of the Clinical Research Committee. She's the past secretary of the Trichy OBGYN Society, organizing secretary of UA Foxy South Zone in 2013. And again, here she has the unique distinction of having won 5 trophies for the Trichy Society, which is again something which is laudable and commendable because very few societies have won so many trophies in a single calendar year. We look forward to her tenure as the ICOG Governing Council member. She takes over in June for that August organization, and she's also incidentally contesting for the post of Vice President of Foxy from the South Zone, and we very soon hope to see her in that post and wish her many more laurels in the future. Next slide, please. We are privileged to have with us Dr. Ritu Khanna, who is the chairperson elect for the Foxy Food, Drug and Medico-Surgical Equipment Committee. She is also the secretary of the Society for Fetal Medicine Varanasi chapter, the vice chairperson of Women Doctors Wing IMA Banaras branch. She was the vice president of Varanasi Society in 2019-20. Secretary for the same organization in the previous year, joint treasurer for the Indian Fertility Society 2018 to 20, and she's organized so many events. The list is almost endless. A very distinguished personality, very well respected, in fertility circles as well. I was privileged to be there with her. She was one of my committee members when I was the Foxy chairperson, and now she is going to be a Foxy chairperson herself, taking over in June very soon. And we look forward to a very long and successful tenure from her and many more laurels in future, of course. So three distinguished stalwarts. It's very difficult to get such eminent personalities as both chairpersons and speakers. So today's event will be something to look forward to. And without further ado, I hand over the proceedings to the chairpersons to take us further. I would request our Vice President, Dr. Rajendra Singh Pardeshi, sir, to introduce our first speaker, Dr. Sagar Kataria, Zonal Coordinator of AMOX.
Good afternoon, everybody. Thank you, Dr. Pratik. So he is doing excellent work in endocrinology and proud to float this CME with our AMOG dignitaries as the speakers, Dr. Sagar Kataria and even Chaitanya Shembekar. Dr. Sagar Kataria, to introduce with, he is Chief Consultant, Kamla Hospital, Satara, AMOG Zonal Coordinator, Zone 2. He is our active zonal coordinator, not only zonal coordinator, active zonal coordinator, organizing chairperson AMOG 2019 at Mahabaleshwar. We cannot forget his hospitality and the successful conference at Mahabaleshwar. Past president, he was Satara OBGYN Society. He was honorary teacher, District Hospital Satara. He is honorary consultant, Arangla Hospital. So I would like to invite Dr. Sagar Kataria for his talk on management of RS negative pregnancy. Over to Dr. Sagar Kataria, sir.
Thank you very much, sir, for your kind information. About me, I am very small amongst the star galaxy of you all people here. Let's start with my topic today. Can I share my screen?
Yes, sir, please go ahead.
Hello everyone. I bring you greetings from Satara. This is a beautiful karst plateau, a beautiful valley of flowers, a World Heritage Site near Satara. This blooming will be in the early winter in the month of September, and I invite you all to view this beauty of nature and the World Heritage Site. Slides are not scrolling.
You can tap on the slides, doctor, it will move.
My personal regards and gratitude to AMOX President Dr. Nandita Palshetkar, Vice President and today's Chairperson Dr. Pardeshi sir, Secretary Dr. Arun Nayak sir, today's Chairpersons Dr. Charmila, Dr. Ritu Khanna, my co-speaker Dr. Chaitanya, and the man behind this show, convener Dr. Pratik Tambe. Thank you, sir, for inviting me and giving me opportunity to present this topic today in front of all of you. Today's topic is modern management of Rh negative pregnancies. Though the topic is modern management, I have included a few basics and old protocols for better understanding of the subject. Rhesus system is one of the 36 known human blood group systems. It is second most important system after the ABO blood group system. It was discovered way back in 1937 by Karl Landsteiner and Alexander Weiner, almost 8 decades back. And in these 8 decades, we have progressed very much in the understanding of this RH system and RH isoimmunization. The RH system consists of as many as 50 defined antigens. Amongst these 50, only 5 are clinically important. And of all, D is the most common and only preventable type of RH group. There are other groups also which do coexist, like weak DU, Kale, MNS, Duffy, KID, and these all can have ABO incompatibility and immunization, isoimmunization. The D is by far the practically D positive is Rh positive and D negative is Rh negative. We don't consider other groups in categorizing the rhesus system. D antigen appears around 38th day of life and it remains lifelong. It is transmitted through a gene located on chromosome 1 by autosomal dominant inheritance. There are two different scenarios for Rh negative mother. If Rh negative mother has married a Rh positive father, if he is homozygous, all the four offsprings will be, all the 100% offsprings will be Rh positive. On the other hand, if father is heterozygous, only 50% of the offsprings will be Rh positive. So when the father is homozygous, there is more likelihood of baby being Rh positive and chances of Rh isoimmunization are more here. Because of this autosomal dominance, the incidence of Rh negative population is concentrated amongst certain communities. For example, the Spanish Basque, every third person is Rh negative. On the other hand, it is very uncommon in Japanese and Chinese population. We Indians stand in between. It is said that amongst Indians, the incidence of Rh positivity is 5%. Rh isoimmunization occur when Rh negative mother is carrying Rh positive fetus. As small as 1 ml of blood is required for stimulating the maternal antibodies. Some few studies have suggested that as low as 0.03 ml of blood can also sensitize the mother and produce isoimmunization. But not all the women will be sensitized and not all women will be having this Rh disease. Almost 30% of the women or the persons having Rh negative blood are categorized as non-responders. So these 30% persons will never develop antibodies even when challenged with large volumes of Rh positive blood. And this is nature's mechanism to protect few people from Rh isoimmunization. Rh isoimmunization, as you all know, it occurs by two mechanisms. Either it appears after the mismatched blood transfusion or it can happen after a fetal-maternal hemorrhage from Rh positive baby to Rh negative mother. Here is the list of various sensitizing events. These events are, as you know, any event that will lead to bleeding per vaginum can cause the Rh isoimmunization. Nowadays, more common is amniocentesis and chorioamnios sampling, and also the platelet transfusions, because we see a lot of dengue patients and ITP patients where we give a lot of platelet transfusions, and the Rh D positive cells can be transmitted through these platelet transfusions. Of course, the most important event is delivery, and the postpartum sensitization is the highest sensitization, amounting to almost 90% of sensitization, while all other causes correspond for the 10% of sensitization of Rh negative mother. How this sensitization happens? When Rh positive cells enter the Rh negative mother's blood system, the D positive antigen on the fetal RBCs evoke an immunological response. Initially, this response is in the form of IgM antibodies. These IgM antibodies are incomplete, they do not cross the placenta and they will not affect much the baby. But they are important in the form that they store the memory in the B lymphocytes. After 2 to 6 months, the IgG antibodies are formed. These are complete antibodies, these cross the placenta and they destroy the fetal RBCs. First pregnancy, usually there is no much sensitization of and no much hemolysis in the fetus because the production of IgG is to a less extent. But if there is re-exposure in the subsequent pregnancy, there is an aggravated immune response forming lot of IgG antibodies. These cross the placenta, attach fetal RBCs and form antigen-antibody complex. These complexes are then sequestered by the macrophages in the fetal spleen. The cells undergo hemolysis and release a lot of bilirubin. The fetus suffers from anemia and hyperbilirubinemia. Without any prophylaxis, there is 16% risk of RH isoimmunization after 2 deliveries. Out of this 16%, 2% occur in the first pregnancy, 7% occur within the 6 months of delivery of first baby, and 7% occurs second pregnancy onwards. Here are the few old terminologies like erythroblastosis fetalis, hydrops fetalis, kernicterus. Today we together all these call as HDFN or hemolytic disease of fetus and newborn. Why these terminologies were coined? Because historically it was found that when this baby's blood was smeared, a lot of premature RBCs were seen on the smear, which are called as erythroblast, and hence the term erythroblastosis fetalis was coined. In hydrops fetalis, the baby is severely anemic. This anemia leads to heart failure and liver dysfunction, producing hypoproteinemia. This anemia hypoproteinemia leads to lot of fluid accumulation in the fetal tissues, and fetus becomes bloated up, and we call it as hydrops fetalis or immune hydrops. When there is a lot of hemolysis in the baby's blood, the bilirubin is released and it reaches very high level. When these levels go up beyond 20 milligrams per deciliter, the concentrated bilirubin can cross blood-brain barrier. Being a neurotoxic, when it enters the neuronal and glial membranes, it destroys the neonatal or fetal neural tissues and causes permanent neural damage. This condition was called previously as kernicterus. Even today we call it as kernicterus. But this all picture together is now known as hemolytic disease of fetus and newborn. While managing these Rh negative patients, we have to take a detailed history, because history always depicts the likelihood of isoimmunization and what are the chances of isoimmunization and fetal anemia in current pregnancy. We have to know detailed history about her prior blood transfusion, the ABO and Rh type of her husband, all the records of previous pregnancies, their outcomes and interventions that were done in that pregnancy, including the Rh including the anti-D administration. For example, if the patient gives history of hydrops fetalis in previous pregnancy, there is 90% chance of recurrence of hydrops in current pregnancy. Also, we have to know whether there was any trauma, vaginal bleeding, or whether any invasive procedure was done for this patient during pregnancy. The management of this pregnancy is twofold. One is prophylaxis. We have to prevent the isoimmunization of Rh negative mother at any cost, and we have to follow strictly the prophylaxis norm. So prophylaxis is for all the non-sensitized Rh negative mothers, while if already the mother is sensitized, then the management is different. Let's see what it is. First, we'll go through the anti-D prophylaxis. Discovery of anti-D is, of course, a blessing of modern obstetrics for Rh negative mother. Before the advent of anti-D, it was in havoc, and such females lost a lot of babies and all the complications they faced. But with the discovery of anti-D, it has come down to a very low extent. Incidence of isoimmunization has come down from 16% to less than 1.6% with the administration of anti-D. This can further be reduced by strict adherence to the prophylaxis regimen and proper dose after calculating the feto-maternal hemorrhage. What we do routinely, everybody knows that we give anti-D at 28 weeks to all non-sensitized Rh negative mothers. Either it is given as a 300 microgram single dose or 100 microgram 6 weeks apart at 28 and 34 weeks. A further dose of 300 microgram is administered within 72 hours if baby is positive. Of course, if baby is negative, no anti-D is given. Suppose if we miss this 72-hour window for some or other reason, it can be given up to 28 days because it will offer at least some protection for the Rh negative mother. All the different Rh sensitizing events that we discussed earlier, up to 12 weeks, 50 to 150 microgram dose is given, and after 12 weeks, 150 to 300 microgram of anti-D is given depending on the expected feto-maternal hemorrhage. Sometimes there is large feto-maternal hemorrhage and this single dose is not sufficient. So we have to know what is the quantity of this feto-maternal hemorrhage. This can be known by two methods. One is qualitative assay, what we call as a rosette test, and the second is quantitative assay or known as Klehr-Betke test. In rosette test, the maternal blood is mixed with anti-D reagent and D indicator red cells are added to it. These D indicator cells attach to the D containing fetal RBCs and they form rosette, which can be seen on the smear examination. If we find many such rosette formations on the smear, then we can be sure of a large feto-maternal hemorrhage. But this is just a qualitative assay. To know the quantity of feto-maternal hemorrhage, we have to do Klehr-Betke test. 1 in 1,000 deliveries will result in a large feto-maternal hemorrhage more than 30 ml, and a routine dose of 300 microgram will not be sufficient for these cases. The Klehr-Betke test is based on the principle of acid elution. The hemoglobin F is more resistant to acid elution as compared to maternal hemoglobin, that is hemoglobin A. After exposure to acid, the maternal RBCs are eluted or they give a ghosted appearance. And on the contrary, the fetal cell remain and they are seen prominently on the smear examination. We can easily count these prominent fetal RBCs, and these RBCs are counted to the count of 2,000, and the number of fetal cells amongst these 2,000 RBCs are determined. It's multiplied by maternal blood volume, which will give us the fetal blood in ml. For each ml of fetal blood, that is 1 ml of feto-maternal hemorrhage, 10 microgram of anti-D should be administered. For example, if there are 36 fetal RBCs in 2,000 population, then it is corresponding with the 90 ml of fetal blood in the maternal circulation, and it will require 3 vials of 300 microgram of anti-D prophylaxis. There are certain special feto-maternal risk states like abortion, where there is 5% chance of sensitization and 50 microgram is recommended. In cases of invasive procedures like amniocentesis or chorioannular sampling, there is a risk of 11% sensitization and dose of 300 microgram is recommended here. In cases of antepartum hemorrhage, 300 microgram is given stat at the incidence, and if pregnancy is continued, then it should be repeated after 12 weeks. In case of external version also, there is 6% chance of sensitization and 300 microgram dose is sufficient for these cases. Now let's see the management in different scenarios of Rh negative mothers. This is a simple case. A primee, she is unregistered, comes directly to you at 28 weeks having Rh negative blood. So how to evaluate this case? What if her husband is Rh negative, and what precautions we should take during labor? If husband is Rh negative, then there is no question of anti-D prophylaxis because there are no chances of Rh isoimmunization. But on the other hand, if husband is positive, then the scenario is different, whether the father is homozygous or heterozygous, and likelihood of fetus being Rh positive or Rh negative. So we have to counsel accordingly. Mother's Rh antibody status can be determined by doing indirect Coombs test or ICT. As per the recommendation, the ICT should be done at first prenatal visit. Previously, it was thought that it should be done at 28 weeks. but there are many sensitization events which are unknown to us, like prior history of transfusion, prior platelet transfusions, some uncommon blood groups. There is also a grandmother theory wherein the Rh negative mother is exposed to Rh positive blood cells when she was inside the womb of Rh positive mother. So such theories recommend that we should do ICT at the first prenatal visit. If it is negative, then it should be repeated again at 28 weeks. If still negative, then we can offer her anti-D prophylaxis. But if it is positive, then no anti-D is given and we should go for titer of ICT. In modern management, we can know the fetal Rh type by doing NIPT or free fetal DNA in the maternal plasma. It is done around 14 to 16 weeks and we can know the Rh status of the baby inside mother's womb. And this can avoid unnecessary anti-D administrations up to 40%. But the cost is prohibitive and at present what we are practicing is a routine anti-D prophylaxis. There are two different tests. One is indirect Coombs test and one is direct Coombs test. The indirect Coombs test will tell us the antibody status while the direct Coombs test tells us the antigen status. The ICT is done on the mother while direct Coombs test is done on the baby. What precautions we should take during labor of such Rh negative mother? We want to prevent the Rh assimilation at any cost. We have already given her the anti-D prophylaxis, but still we want to preserve the mixing of fetal and maternal blood. So the principle of management of labor in case of Rh negative mother is be gentle. No fundal pushing. The cord should be clamped immediately. There should be no squeezing of cord before clamping. Leave a long length of cord about 15 to 20 centimeters because it may be needed for further exchange transfusion if required for baby. Send the cord blood for blood group, direct Coombs test, hemoglobin, hematocrit and bilirubin estimations. Let the placenta be delivered spontaneously. Don't pull, twist or avulse the cord. Protect vaginal perineal wounds, lacerations from being exposed to fetal blood spilled from cord and placenta. No ergotamines should be administered because they will increase the fetomaternal hemorrhage. No uterine massage, uterine grasp or squeeze, what we practice sometimes after the delivery. During C-section, adequate packing to avoid the spillage of blood inside the peritoneal cavity, and also cleansing of uterine cavity is important. So this was a simple case of unsensitized pregnancy. Let's see one more case. She is third gravida. She had delivered 2 babies previously. There is no record. Don't know whether she was given anti-D or not, and she is Rh negative. So how to evaluate this case, whether to give anti-D or not, if given in what dose, let's see. Again here, we should do ICT or indirect Coombs test at the first visit. If it is negative, manage as a non-sensitized pregnancy, give her anti-D prophylaxis. If ICT is positive, then no anti-D is given. We should go for anti-D titer. As long as anti-D titer is less than the critical value. See, this anti-D titer is estimated by doubling the dilution. So initially the titer is 1:1 positive. Then after dilutions, it becomes 1:2 positive, 1:4, 1:16, 1:64, and like this. So if as long as the titer is less positive in less than 1:16 dilution, then routine monitoring is done, and we have to do this anti-D titer every 2 to 4 weeks. Once it reaches the critical level of 1:116, there is a significant risk of fetal anemia and hydrops fetalis. In such cases, we have to do more frequently the anti-D titers, and still better, we can monitor these patients with MCA PSV Doppler. We'll see in the next case. Nowadays, most of the management of Rh negative sensitized mother depends on MCAD, that is MCA Doppler velocimetry. In unaffected or mildly affected fetuses, the MCAD is done every monthly and the pregnancy is continued till term, and after the lung maturity is achieved, we can deliver the baby. Here there is very low risk of intrauterine fetal demise. If the MCA PSV is less than 1.5 multiples of median, then we have to repeat this every week, and once it reaches the lung maturity, we can deliver this baby. But once the level goes above 1.5 multiples of median, that is mom units, there is a frank risk of fetal hydrops and high risk of intrauterine fetal demise. So here the delivery should be achieved as early as possible depending on the MCA values. This all we will discuss in this case. This is fourth gravida. She had first ectopic pregnancy. The second was 25-week fetal loss. Third was abruption and intrauterine fetal demise. She had received anti-D at each event. Are there still chances of isoimmunization? Why? And what is the role of ICT here? In such cases, there is high probability of isoimmunization because of large fetal hemorrhage. Even if anti-D was given at each event, still it may have been inadequate, and such patients are very likely to have already sensitized. Most of the times, the dose is not calculated using Kleehor-Betke test because it's not easily available, and adequate prophylaxis is not given in most of the cases. So when we do ICT in such patients, it becomes positive in high titers. Again, the management is same. As long as the titer is less than 1:16, we have to monitor at every 2 to 4 weeks interval. And once it crosses the critical level of 1:16 titer, then we have to monitor it more frequently. The intensive monitoring is to avoid the fetal hydrops and stillbirth at any cost. It can be done with the following methods. The most commonly used method nowadays is MCA PSV Doppler. This is a standard. Previously, the amniocentesis and Lilly's and Queen chart was used. Also, we can know the direct fetal hemoglobin and hematocrit values by doing fetal blood sampling. What is the sonographic picture in these cases of severe fetal anemia and fetal hydrops? The earliest indication is said to be visualization of fetal bowel wall due to small amount of ascitic fluid present in the fetal abdomen. As there is more and more damage, the placenta becomes thickened, the umbilical veins get dilated, there is hepatosplenomegaly, there is polyhydramnios. These are all early signs or intermediate signs, and when it becomes a full-fledged fetal hydrops, it presents with fetal ascites, pleural effusion, skin edema, cardiomegaly, and halo around the fetal skull. This is a terminal stage, and we should not allow the patient or the fetus to proceed to such a state. How this MCA Doppler is done and what is its importance? The MCA Doppler is done to know the peak systolic velocity of the blood flow in middle cerebral artery. It is reliable from 18 to 35 weeks. Before 18 weeks, the fetal reticuloendothelial system is not developed that much, and so there is less chance of fetal hemolysis. While after 35 weeks, the MCA PSV is not that reliable for detection of fetal anemia. The anemic fetus preserves the oxygen delivery to brain by increasing the cerebral blood flow, reflecting it as an increasing peak velocity in MCA PSV Doppler. These values of PSV are plotted as multiples of median for that gestational age. So every gestational age has a different multiple of median for the MCA PSV value. The sensitivity of detecting severe fetal anemia approaches almost 100% when the MCA PSV values are more than 1.5 mom units, and it is highly reliable thus. Here are the two slides. The first one is a normal baby, where you can see that peak systolic values are low, while this is an affected pregnancy and fetal anemia. Here you can see that the PSV is very high, and as the baby progresses and more anemia is there, the peak systolic velocity also rises more and more. The use of MCA PSV has resulted in up to 80% reduction in invasive testing, reduction in the invasive testing like amniocentesis and chordocentesis. Amniocentesis, just for an academic purpose, it is an old method. It is largely replaced today by MCA Doppler. It was done when the ICT titer is very high, beyond the critical level of 1:16, or if there is history of previously affected baby or previous history of hydrops, then in such cases amniocentesis was used to be done around 27 weeks. Avoiding placenta, the amniotic fluid sample was obtained and it was subjected to spectrophotometry at optical density of 450 nanometers, which this optical density correlates well with the fetal hemolysis and bilirubin content of the amniotic fluid. So this data obtained on the spectrophotometry was plotted against that gestational age in Lilly's or Queenan chart, and the zone risk was assigned as zone 1, 2 or 3. In zone 3, it was as sensitive as 98% of the cases can be detected by this charting of amniocentesis and optical density charts. The first one is Lilly chart. It is beyond 27 weeks up to 40 weeks, while the Queenan chart tells us the values from 14 weeks onwards. So depending on the baby gestational age, any of the charts can be used. The risk is assigned as per the zone 1, 2, 3. Zone 1 is mild risk, zone 2 is moderate risk, and zone 3 is indicative of severe fetal anemia with impending fetal demise within few days. Now let's talk about how to manage already sensitized pregnancy with very high titers and very high MCA PSV values. This is a clear-cut case of RH isoimmunization or RH disease, and most likelihood of severe fetal anemia is there in these cases. The fetal anemia can be detected either by amniocentesis or by chordocentesis by doing fetal blood sampling or by ultrasound measuring the MCA PSV values and plotting against the gestational age. The treatment of these cases is of course by correction of fetal anemia by intrauterine transmission and timely delivery. Let's see how to do these cases. Today, 80 to 90% severely anemic babies can be saved by intrauterine transfusion. The indication for intrauterine transfusion is fetal hematocrit value less than 30%. And the target is to achieve the fetal hematocrit more than 50%. The amount of blood transfused is decided by the formula of 0.02 into fetal weight in grams. For example, for 1 kg baby, 20 ml of blood is required. It can be, mostly it is done through umbilical vein, but if it is not accessible, it can be done intraperitoneally or both can be done. The donor blood is selected on the different criteria, that is, it should be always O negative blood. The packed cell volume should be more than 80%. It should be fresh as far as possible, less than 5 days old. It should be screened for transfusion transmitted diseases, and it should be irradiated if possible. Now, how this procedure of intrauterine transfusion is done? It is always done at a recognized center of under the PCP entity, the center which is recognized for invasive procedures, and it should be done always by a fetal expert in fetal medicine. Here the mother is sedated Doing ultrasound, we can determine the position of fetus and placenta. All the aseptic precautions are used. A prior dose of antibiotic and tocolysis can be given. It is done usually under local anesthesia with left lateral tilt. Umbilical vein is entered avoiding the placenta, and fetal cord blood is obtained for hemoglobin, packed cell volume, and blood gas analysis. At the same time, the pancuronium is injected inside the umbilical vein in the dose of 0.3 milligram per kilogram of estimated fetal weight to achieve fetal paralysis, so that further procedure of transfusion becomes easy. Start the transfusion, infuse half of the blood that is quantified for transfusion, check fetal hemoglobin and packed cell volume, rule out fetal bradycardia, which is very important side effect of this intrauterine transfusion. Infuse the remaining amount to achieve the targeted value of fetal hematocrit levels of 50%. After doing this transfusion, the monitoring is done with MCA PSV every week or every 4 days. Depending on the MCA PSV values, transfusion can be repeated every 2 weeks till we achieve sufficient maturity for delivery of the baby. Steroids can be administered for enhanced pulmonary maturity, and delivery can be timed. Intrauterine transfusion has become increasingly common and relatively safe procedure with the availability of high-resolution ultrasound and color Doppler, various experts in the fetal medicine area, and better understanding of Rh isoimmunization. After the intrauterine blood transfusion, there is dramatic improvement which can be seen in MCA PSV values after a successful intrauterine transfusion. These are the two slides. The slide above is before the transfusion. You can see a long high PSV value in this case, and the slide at bottom is after the transfusion. You can see that PSV value has come down drastically. There are few alternative treatments for Rh negative pregnancy, which is already isoimmunized or alloimmunized. Many have been tried over the last decades, but there is no evidence and nothing has been standard on the grounds of standards. Different methods that can be used are plasmapheresis, administration of steroids, administration of intravenous immunoglobulins, and few drugs like promethazine. Early detection of fetal anemia using MCA PSV, intrauterine transfusion, and timely delivery remains the gold standard for Rh isoimmunized pregnancies. What are the recent advances in this field of Rh isoimmunization or management of Rh isoimmunization? We can do NIPT for free fetal DNA at 14 to 16 weeks to know the fetal Rh status, so that we can know the risk of Rh isoimmunization, and accordingly we can administer the anti-D prophylaxis. Nowadays, direct estimation of anti-D can be done instead of doing ICT titers. As long as anti-D levels are less than 4 international units per ml, there is low risk of fetal anemia or HDFN. If the levels of anti-D are between 4 to 15 international units per ml, there is moderate risk of fetal anemia. But if the levels are more than 15 units, there is very high risk of fetal anemia, and such patients should be very carefully followed. So we can do this direct estimation of anti-D levels. The quantitative estimation of fetal-maternal hemorrhage can be done nowadays by using flow cytometry instead of the complicated Clee-Betke test, which is very less available. Nowadays in Western countries, the flow cytometry is used for detection of quantity of fetal-maternal hemorrhage. Of course, nowadays the MCA PSV has been the gold standard for management of Rh isoimmunized pregnancies from 18 weeks onwards. We can do direct fetal blood sampling for detection of fetal anemia also. So is that picture all rosy? Don't we have any problems? There are a lot of problems in our setting, especially in the peripheral districts like Satara and the peripheral villages. The RH immunization still is a major problem. Because of high cost of immunoglobulin, patient may avoid taking anti-D prophylaxis. There are lack of resources to adequately investigate and monitor the fetus inside the womb. There is low turnout of patients for antenatal clinics and many of the RH negative mothers are missed. There is poor documentation of prior events, prior deliveries, lack of case notes and proper records is always there. So how to overcome this? Here are few recommendations. There should be a partnership between government and NGOs to help provide subsidized cost of anti-D prophylaxis for poor patients. Special insurance cover should be made available for RH negative women to cover all the expenses needed for our management. Involvement of clergymen as a part of premarital counselors to see the blood group of the couple. In this era of WhatsApp and Facebook, we can create special fora or groups of RH negative people which can talk with each other and experts can give them different advices. So with this, I come to end of my talk. Here are some take-home points. Every woman of childbearing age should have her ABO and RH blood group done at the first contact. ABO and RH group of husband should be obtained when the mother is RH negative. Ensure ICT is done at the first visit and at 28 weeks of pregnancy with administration of appropriate anti-D prophylaxis. A single postpartum dose of 300 microgram may not be adequate in all cases, especially in cases where large fetal-maternal hemorrhage is suspected. And modern management with MCA, PSV, intrauterine transfusion can salvage most of the severely affected HDFN cases. Managing RH negative mother was a dreadful and scary scenario a few decades ago. Change scenario today is a miracle of modern obstetrics and fetal medicine. Introduction of anti-D has brought down the risk of isoimmunization to very low levels. At the same time, MCA Doppler and intrauterine transfusion has dramatically improved the outcomes of severely affected fetuses, and majority can now be salvaged with proper management. So this is all for today. Hope I have covered most of the things. Here are experts with us who will enlighten us further for any shortcomings in my talk. Thank you, Dr. Pratik, for inviting me to this auspicious lecture on this auspicious day of Mahashivratri, and greetings of Mahashivratri to all. Thank you.
Thank you, Dr. Sagar. He has explained very nicely the process of FMH, role of womb stress, antenatal and postnatal management of sensitized RH negative woman, role of Doppler in the management, that is middle cerebral artery verometry, and amniocentesis, even if legality is also PC he has really narrated very nicely. Thank you so much, Dr. Sagar.
Thank you, sir. Thank you for your kind words.
Ritu,
yeah,
your comment.
Yeah, thank you so much, sir. Dr. Sagar, it was really a crystal clear, I must say. It was a presentation, wonderful. And we thought it'll go on and go on. So it was very nice. And so we'd like to have a few questions which are there. Could I take them up right now, Dr. Pratik?
We can do them at the end of the session, ma'am.
Okay, fine,
We'll
sir.
have the questions for both
Right,
speakers
sir.
together.
Right.
We'll do them at the end. Thank you, ma'am.
Right. Thank you so much, sir. Dr. Chamila.
It's my honor to introduce our next speaker, Dr. Chaitanya Shambekar. It's a great CV which I'm seeing, and he's a past president of the Nagpur Society. He's the chairman of the Infertility Committee of AMOGS, executive member of the Maharashtra ISAR, member of the Infertility, Endocrinology and Endoscopy Committee of FOXI. He's been the recipient of the Kamini Rao Yuva FOXI Oration Award. He's won several awards, gold medals, done so many orations in almost 50 FOXI societies, has been a faculty in various national level conferences. He's a great researcher, has published almost 15 articles in journals with 2 international publications, and has contributed chapters in almost 6 textbooks. He's a guide and mentor for MUHS and ICOG post PG fellowships at his Omega Hospital, and is a member of the PCP Unity Committee, Nagpur. I would like to welcome Dr. Chaitanya to talk on the subject targeted investigations to fertility treatment.
Thank you, Dr. Shamila. And I would start screen sharing now. At the outset, I would like to thank AMOGs, Dr. Nandita Parshetkar, Dr. Arun Nayak, and Dr. Pratik Tambe for giving me this opportunity to speak on this very basic, but I think equally interesting topic. I bring greetings on the auspicious occasion of Mahashivratri, and we will start discussing about how to go ahead with the investigations of infertility. The first question is when to start investigations, and this is a question which everybody. So you have to begin after 12 months, which is a standard definition of infertility. So whenever a couple comes to you, if it's a 12-month duration, then you label it as infertile couple and you start investigating. But then there are some things which are changing nowadays, and it is said that if the age is more than 35 years, then you should start investigating within 6 months. If age is more than 40 years, which is now becoming common because of the late marriages, you should immediately evaluate the couple. And especially in Indian scenario, if the age is more than 32 years, you should start investigating within 6 months of marriage or sexual intercourse without protection. There are some points which I will discuss later, and that is regarding subfertility and unexplained infertility, which we will be discussing later on. So there is an article which appeared in Fertility and Sterility regarding ethnicity and diminished ovarian reserve, and it is said that ovarian age is 6 years ahead in Indians as compared to Spanish women. So if you compare Indians and Asians with the Caucasians, you'll find that in India, you should actually start investigating couple after 6 months of marriage if the age is more than 32 years, because their ovarian age is ahead, which is 6 years ahead of Spanish women. So the time is ticking, and you should not waste time and should not wait for more than 6 months. So this is the message which is loud and clear, and we all should carry forward this message to the society, and you should start, you should marry early, and you should have childbearing as early as possible, especially in Indian ethnicity. So we were discussing about subfertility, and as I told you, subfertility is something which is any form of reduced fertility with prolonged time of unwanted non-conception. That means whenever the conception is wanted and the time taken is prolonged, you can actually start doing workup. And this period usually is of 6 months. So 6 months period is usually a period of subfertility, where the patient is not a known case of infertility. But when you investigate such couples, you identify the problems, and you will get 2 types of situation. One situation is there is absolutely no problem. That means the patient belongs to probably unexplained infertility group, and here you can afford to wait. And second is a major problem, like suppose there is a tubal block or the patient has got grade 4 endometriosis, where you cannot actually wait, you have to intervene. So in subfertility, the advantage is that it will avoid under treatment as well as over treatment, and that is the biggest advantage if you start just investigating the couple a bit earlier. Now, whom to offer investigations? Any patient who by definition is infertile or any patient who is at high risk of infertility should be offered investigations. Now, I'll give you the clinical scenarios in our day-to-day practice. This case is a case of Kalyani. Kalyani is married since 8 months. Her age is 33 years. Her mother was worried as according to her, it was late marriage. By the time she was 33, Kalyani was already 8 years old. So she asked Kalyani to consult her doctor, and Kalyani too is anxious because she wants to conceive early. Now, will you start investigating this patient? Yes, we will start investigating Kalyani because Kalyani is Indian. She is 33. So we must investigate her even though she is married since only 8 months. So definition of infertility 1 year does not apply in case of Kalyani because she is Indian and she's already 33, so you should start investigating her right away. Isha is 23-year-old with irregular cycles. She's married since only 2 months, but she knows that she has a problem. She gets menses only after taking withdrawal. She's obese, she's hirsute, and she knows she is a case of PCO. So she's very anxious. Now, will you investigate her? The answer is yes. So Isha, though young, knows her problem and is high risk of infertility. And though married since only 2 months and still young, you should actually start investigating her because she might require some support for fertility treatment. Now, a case of Neha. Neha is a very typical situation. This is the situation which we see nowadays very often. The philosophy of Neha and her husband is life's best moments usually happen unplanned. So they are just not bothered about any planning for conception. They are not willing for investigation. Neha is 37 years. She is already advanced age, if you call it, as far as the fertility is concerned. She is married since 5 years, but she is just not interested in conception. She is a freelance journalist. Her husband is a travelogue writer, and they are busy with their profession. She is just not willing for conception. What is your role? Your role is to counsel them as advised by mother-in-law. As we know that mother-in-law, they come to us and they say, doctor जरा सांगा समजावा यांना, या लोकांना काही इंटरेस्टच मुलगा नकोच आहे. So you have to investigate her. The answer is yes. And Neha, though Neha is not interested, it is your especially in Indians, that please marry early and please have childbearing as early as possible. Infertility group of Italy, they call it Infertility group, has given guidelines in January this year. And this is a very interesting article. Why? Because they have given practical, clinical, and diagnostic pathways for the investigation of the infertile couple. And we will just go how to go ahead with the investigation. The first thing first is to identify the risk factors. So you must know what is the risk factor. Like, though we know that the infertility is a problem of both husband and wife or male and female partners, there are several factors which are more common in some sexes. Like, suppose you take consider age. Age is having more impact as far as females are concerned. So we are more anxious about the age factor in the females as compared to males. Though in males, the fertility declines usually after the age of 50 years. We know that in women, after 35 years, there is a drastic reduction in the fertility, and after 40 years, the reduction is more severe. There are many other factors like BMI, smoking, stress. Infection is becoming more and more common nowadays, especially in India. Tuberculosis was always there and is always there and will always remain there. PCOS is still important, but the new normal is diminished ovarian reserve. So you have to be extremely careful about the diminished reserve of the ovaries and the premature ovarian insufficiency in the patients who are coming to you for treatment. So this is a chart which actually gives you idea about the risk factors. So first thing to do is just identify the risk factors, like suppose age in females, the testicular cancer history in males, or testicular torsion in males, or smoking in males, or infertility with previous partner in both the partners. These are the things which will give you a clue that probably there is some problem and that's the reason why they are not conceiving. Now, after this, the thing which we usually tend to forget, and here I would like to give special mention on this, is that you should do general investigations of both the partners, because you have to treat them during pregnancy and you cannot just afford to, miss something like hemoglobinopathies, miss something like HIV or retrovirus infection. Or you should also do the cancer cervical cancer screening, rubella screening, and especially if the age of the woman is more than 40, then you must do echo ECG and get the fitness from a physician, because especially in IVF we are getting more and more patients with advanced maternal age and they are having multiple problems, and therefore it is our policy at Omega Hospital that we always do echo and take a physician opinion from a cardiologist opinion before we go for IVF in patients where the age is more than 40 years. So this is something which we all should know. It's small thing, but which matters a lot. So how do we proceed? If you look at an infertile couple pathway, the pathway to pregnancy in infertile couple is usually long. It requires high level of resilience owing to several factors. These include medical procedures, economic cost, socio-economical factors, and psychological factors. So you need a multidisciplinary approach. You should have a gradual approach. You should not have haste in doing investigation. You should not look hasty. You should do it gradually, and you should reduce invasive procedures as far as possible, which are not necessary. So do not do invasive procedure unless they are indicated. So in females, the patient comes to you, you take the history, proper history of the patient, do examination and do transvaginal sonography. A good transvaginal sonography is something which is the preliminary investigation in any patient coming to you for infertility. Similarly, in males, you have to take history and you should do semen analysis, which should be as per WHO standard 2010 criteria and should be done from a proper person. And if required, you can do examination by andrologist and sonography from a sonologist. So this is how the male should be approached. So after doing semen analysis, proper history, examination, and sonography of the patient, you have to know what are the indications for immediate evaluation. Suppose that if there is a male suspected male partner factor or male infertility, you should do immediate evaluation. If there is oligomenorrhea or amenorrhea to the patient, known or suspected uterine, tubal, or peritoneal diseases like tubal block or stage 3 and stage 4 endometriosis are the situations where you should do immediate evaluation. So you should know that these are the conditions where you just cannot afford to wait. You have to immediately start treatment. So how do you evaluate the patient? As I told you, the first three things which you have to do is history, proper examination, and ultrasound. After doing these three evaluation, you have to do pre-pregnancy evaluation as well, which includes the investigations, which includes the basic investigations, and then you should start investigating for the evaluation of the etiological factors of the infertility. So what are the etiological factors? The first category is diminished ovarian reserve or ovarian reserve testing. So you do ovarian reserve testing to know whether the patient has got PCOS or hyper response or diminished ovarian reserve. So you do an AMH level, you do FSH, you can do E2, you can do transvaginal sonography to know the ovarian reserve testing. Then second is ovulatory dysfunction. That means ovulation function test, which also includes ultrasound and serum progesterone level. Then tubal testing with the help of HSG and hysterosalpingo contrast sonography, and then uterine factors, which can be done with the help of sonography and if required hysteroscopy and if required histolaparoscopy. So that is how you evaluate. But what is important is test which should not be done routinely. क्या करना चाहिए, इससे ज्यादा हमें क्या नहीं करना चाहिए, ये पता रहना चाहिए. Because these are the tests which should not be routinely ordered, and if you routinely order them, then you are not a good fertility specialist. You are doing something which is not expected from you. So do not do laparoscopy for unexplained infertility. Do not do advanced sperm function testing unless it is required, like DNA fragmentation testing. Post-coital testing should not be done. Thrombophilia testing should not be done. Immunological testing like anti-nuclear antibody or antiphospholipid antibodies or anti-sperm antibodies should not be done unless it is required. Karyotyping should not be done. Endometrial biopsy, there is no role of endometrial biopsy, and prolactin level should also not be done unless there is some indication for doing this test. So these are this. You can take a screenshot of this slide because this slide is important, especially for those who are new in infertility practice. They should know what not to do, हमें क्या नहीं करना चाहिए, ये सबको पता रहना चाहिए. So before we proceed further, a word about unexplained infertility. This is a separate topic. 30% of the patients will have unexplained infertility. So you do testing of the patient. One tube is patent, at least one tube patent. Documentation of ovulation is there, and semen analysis reports are normal. You call this patient as a case of unexplained infertility, and you should explain the unexplained, that what to do and how to go ahead. Ideally, you should wait for 2 years, but most of the patients, it is not practical to wait. But the good news is that most of the patients, they conceive within 2 years, but you cannot afford to wait. So the guidelines say, especially the ASRM guidelines say, that you should do IUF for 3 to 4 cycles, followed by IVF if required, if there is no successful pregnancy after doing ovulation stimulation and IUI cycles. So that is what the guidelines say. Now we have to go ahead with the investigations, and while going ahead, you should have a protocol. You should have fixed ideas in your mind how to go ahead. And here you can divide this on the basis of time for offspring search or the duration of infertility, whether it is less than 12 months or more than 12 months. WHO says that couple should be divided based on the time of offspring search. And WHO recommends preconception care. This is very important. Whenever you are treating the patient, at the same time, start folic acid. Give them idea about the conception. Tell them about what to do and what not to do. So preconception care is something which should be started 3 to 6 months before trying for baby. And here you do 3 things, that is medical history, examination and ultrasonography, and start preconception care. So this is true when the couple comes to you with duration of infertility less than 12 months. if the duration is more than 12 months. So what will you do if it is more than 12? So if it is less than 12 months, you do this basic test and wait till the 12-month period is over. But if the patient comes to you and the duration of marriage is more than 12 months or duration of unprotected intercourse is more than 12 months, then you cannot wait. You have to do something for them. And in males, you have to investigate for infections. And in females, you have to investigate for ovarian reserve testing. So what we do, so this is how we go. If the duration is less than 12 months, just try to do the three basic things. Find out the cause. If there is a cause, treat the cause. If there is no cause, wait for 12 months to finish. If the duration is more than 12 months, in females, try to find out the cause. If you don't find cause, do ovarian reserve testing. And in males, if you don't find any cause, do the infectious disease screening. And if you find that there is some infection, then treat the infection and then do the repeat testing and then start the treatment. So that is the way you should go ahead if the patient has got duration less than 12 months or more than 12 months. Now, as I told you, you are on crossroads. You have done three investigations. The patient is married since or trying since 12 months. More than 12 months period is over. Start ovarian reserve testing. And here you do AMH, FSH, antral follicle counts, and other things. And if you find that the patient has got diminished ovarian reserve, you should go for aggressive treatment, and that treatment is in the form of ART and, if required, of course, IVF. So age is crucial here in this situation. If particularly if the age is more than 35 years, then you cannot afford to wait. If ORT reports are normal, then here you have to consider two factors: the age of the patient and the duration of the unprotected intercourse. If the age is less than 35 years and the duration is less than 2 years, you can do tubal patency testing. And here the treatment or the investigation of choice is HSG or saline sonography and not laparoscopy. So HSG or saline sonography should be done, and then you can do IUI for 3 to 4 cycles. If the tubes are blocked on HSG, then of course you can go for laparoscopy, try to cannulate and open the tubes and go for IUI. And if the tubes are still blocked, you can go for IVF. Then, so this is the situation where the patient is married since less than 2 years and the age is less than 35 years. So you do the patency testing and do IUI and do laparoscopy if it is required and IVF if it is required. Now the next category, the third category, is where the patient's age is more than 35 years but it is less than 40 years. Here again, you have to do the patency test first, and you can try for IUI still in such cases, but not more than 3 cycles of IUI. So here, initially, I still remember we used to say do 6 cycles of IUI. Then the criteria was 4 cycles of IUI. And now, especially when the age is more than 35 years, you should not go beyond 3 cycles of IUI. This is something which should be clear in your mind. If the patient has got PID, patient has got hydrosalpinx or endometriosis, then you can do laparoscopy, do delinking, and go for IVF. So it all depends on the situation. So more than 35 years, you have to do the AMH and AFC. If they are normal, then tubal patency and then IUI for 3 cycles maximum, followed by IVF. If the age is more than 40 years, what will you do? There is no question of doing anything. The patient is straight away for IVF. You have to tell her that your age is more than 40 years. There is no point in wasting time. Go for immediate IVF treatment. Now some hormonal levels. Now this is about the flow charts which we have discussed, the algorithms we have discussed now. Now we'll go into the details of some investigations. The first investigation is the blood investigation. And this is something which we all should know because day in and day out, we come across the patients and we have to look for the significance of each and every test. So what is the significance of FSH? FSH is something which is done on day 3 and the normal level of FSH is 4 to 8.9. If it is more than 9, that means there is diminished ovarian reserve, and if FSH is more than 25, you call it as premature ovarian insufficiency. That is the diagnosis of POI, FSH more than 25. E2 levels are done again on day 3. They should be between 30 to 80 picogram per ml. If more than 80, that means there is some functional cyst. If they are low, that means the patient has got WHO group 1 or group 3 category and therefore they need treatment. E2 levels on the day of LH surge. This is important because you know that the follicles are formed and every follicle is secreting estrogen. So it is said that every mature follicle will secrete 150 to 200 picogram of E2, and therefore it should be minimum 200 on the day of LH surge, which means that ovulation is taking place. Then LH levels. Day 3 should be 3 between 3 to 10. High LH level are suggestive of PCO. LH FSH ratio is something which we do not do nowadays, but high LH is suggestive of PCO, and low LH is suggestive of hypogonadotrophic hypogonadism. LH on the day of surge should be more than 20, which suggests ovulation within 48 hours. Prolactin is something which should not be routinely done. We have already discussed that, but prolactin levels are, if they are high, that is suggestive of prolactinoma. Progesterone levels are also equally important. In fact, they are very important because you don't expect progesterone to rise in the secretory phase and in the initial pre-ovulatory phase. And here on day 3, if the progesterone level is less than 1 nanogram per ml, that means the pregnancy rate will be low. And on the day of 21 day 21, where the ovulation has taken place, the progesterone level should be more than 5 nanogram per ml. And if it is more than 10, that is suggestive of adequate luteinization. AMH level can be done on any day of the cycle. That is the beauty of AMH. It should be between 1.2 to 3.5 nanogram per ml, and there is no universal consensus as far as the AMH levels are concerned. But if AMH levels are more than 3.5, we label it as PCO, and if it is more than 1.1, we label it as diminished ovarian reserve. TSH is something which should be between 0.3 to 5, but nowadays the aim of the fertility specialist is to keep TSH levels below 2.5 so that there is no subclinical hypothyroidism. Now we have discussed all the criteria about the investigation protocols which we all should follow in our day-to-day practice. Now I'll ask you 3 questions. और ये 3 सवाल जो है ये 3 बहुत अहम सवाल है क्योंकि इन सवालों से हमें आगे का इन्वेस्टिगेशन का प्लान डिसाइड करना है. The first question is USG replacing most of the targeted test? The second question is, are day 2 hormonal assays losing its significance? And the third question is, are sperm function test replacing semen analysis test? And the answer is maybe yes. We don't know. We will discuss this. So the first thing is ultrasonography. And in ultrasound, it is said that the volume ultrasound with 3D, Paul Doppler, color Doppler, transsonography, and Sono AVC vocal ultrasound is supposed to be the best ultrasound. So we have got all these volume machines, volume ultrasound machines, which are becoming more and more popular nowadays because they give you idea about so many things, and they are so necessary in our day-to-day practice as far as fertility practice is concerned that they are actually replacing almost all the investigations. How they are replacing all the investigations, we'll discuss now. So what should be the approach? The patient comes to you, we say that the first 3 things which are there, basic things include ultrasound, history taking, examination, and transvaginal sonography. In TVS, we do a general TVS, which is done on any day whenever the patient comes to you, and then we do cycle assessment scans. And we must do ultrasound, cycle assessment scan, and ultrasound is not complete unless you do cycle assessment scan. That means you have to assess the patient in every stage of menstrual cycle, and then you come to know whether the things are going in the right direction or not. So here we go. The first thing is we put the probe inside and see the uterus, the position of the uterus, the size of the uterus, the shape of the uterus, whether it's antiverted or retroverted. See the surface of the uterus, see the myometrium, see the endometrium, and also see the adnexa. After doing this, we come to know about so many things. With 3D ultrasound, the uterine abnormalities are so nicely detected that it is said that it has got a maximum sensitivity and specificity. You see this chart, you will find that maximum sensitivity and specificity is there with volume ultrasound. So 3D volume ultrasound gives you the best result for the diagnosis of uterine anomalies. Second is fibroids. You do put the TVS and you do fibroid mapping. You can exactly do the FIGO classification of the fibroids with the help of TVS. You put the color and see the vascularity of the fibroid. You put the volume probe and see whether the fibroid is invading the cavity or not. and you do the power Doppler and see whether the blood supply to the fibroid is reduced or not after giving treatment like GNRH analogs. So you come to know so many things. You see the blood supply, you see the invasion, you see the response to the treatment to the fibroids with the help of these beautiful machines which are now available in the market. In adenomyosis, you also will be able to see the asymmetrical thickness, so thickening of the wall. You will be able to see the Swiss cheese appearance, which is classical of adenomyosis. You will be able to see put the color. You will be able to see the color flow in the adenomyoma, and you will be also be able to differentiate it from the fibroid. If you are not able to differentiate, then you may have to do MRI, but usually ultrasound can also help you differentiating adenomyoma from fibroid. Then you go to the endometrium and see a classical pear-shaped endometrium. You have to focus on the junctional zone, and this junctional zone has to be intact. See for the shape, the contour, and the disruption of junctional zone, if any, and you may be able to diagnose acute and chronic endometritis on ultrasound. If there is collection and increased vascularity in early stages, there is a increased vascularity, which is suggestive of acute endometritis. And in chronic endometritis, the endometrium becomes thin, it is avascular, and you may get calcified spots in the adnexa, which will give you idea about probably there is a chronic infection like tuberculosis or chronic endometritis. Endometrial thickness will give you idea about hyperplasia. You can see the polyps, the synecdoche on 3D ultrasound. The best thing to see for the polyps is to do the saline sonography, and you can actually see the polyp. Then 3D also gives you idea about the polyp, and then you put a color, and you will be able to see the stalk, and you will be able to see the feeding vessel inside. This is so nice. And if there is a Asherman syndrome with 3D ultrasound, you will be able to see the synecdoche in the best way. Then you see for the ovarian lesions like ovarian cyst, which is simple cyst, or you can see hemorrhagic cyst in the form of echogenicity. You get a classical ground glass appearance, which is suggestive of endometrioma, or you may get calcified spots and classical of dermoid cyst. So you will be able to see the adnexa and will be able to diagnose. And you will be also be able to see the tubal lesions where you see a classical sausage shape hydrosalping. You have to just change the direction of the probe, rotate the probe in such a way that this lesion becomes elongated. You see the incomplete septa, and you put the 3D, and you see such a nice picture of hydrosalpings. So that is the beauty of ultrasound machine. There are some procedures which you can do: saline sonography, saline sonohysterography, hycosi, and saline infusion sonography, which will give you idea about the tubal patency and so many other things on ultrasound. So that is the reason why I said that you don't have to do HSG also nowadays because of hycosi and saline sonography. So you see the PCO or ovarian reserve, then you do endocrine evaluation. Fibroids, you may do hysteroscopy. You see hydrosalping, you may do laparoscopy. So you decide depending on the ultrasound picture how to go ahead. So ultrasound is such a important scan. Then on ultrasound, there is a cycle assessment scan. And unless, as I told you, you do cycle assessment scan, your sonography is not complete. So this is a baseline scan which is done on day 2 of menses. Then there is a pre-ovulatory scan and there is a secretory scan. So these are the 3 scans which are to be done. In a baseline scan, if you have a sono-AVC application in your machine, then you are able to see the follicles and antral follicles. So that is called as sono-AVC for AFC, where you will be able to see these antral follicles so nicely. And this is called as sono-AVC for AFC. You get actually the number of antral follicles which are there in a 3D view. That is the beauty of this machine on day 2. Along with that, you see the echogenicity of the stroma. You see if there is any cyst, and you will be able to classify ovary into 4 categories depending on how many follicles are there: normal ovary, PC ovary, low reserve ovary, and a poor reserve ovary. Then you will be able to also be able to see the hyperechoic stroma, which is suggestive of PCO, or a stromal density, which is suggestive of PCO. And as I told you, sono AVC for AFC is the best thing which can give you idea about so many things. Then you see the endometrium, it has to be thin. If it is thick, that means there is more functional cyst or maybe more estrogen, which is giving you thick endometrium on day 2 of scan. And you put a Doppler in the uterine artery and see the blood supply to the uterus. If RI is more than 0.79, which is suggestive of high resistance, then you will require high doses of gonadotropins for the stimulation. So see the clinical application. You put the Doppler in the color uterine artery, you see the resistance. If there is a resistance, that means you require high doses of gonadotropins. You on day 2 you come to know about the dosage of gonadotropins by doing uterine artery Doppler. So that is the beauty of the Doppler machine. Then comes the pre-ovulatory scan. You do the follicle testing. You see the dominant follicle, and this is the Sono AVC for AFC, follicle. So for Sono AVC for the follicle count, and this is something where you actually get idea about the number of follicles and size of each follicle. And then if the follicle is mature, it will be rounded, the margin will be thin, there will be no internal echoes. You will see that the Doppler flow is covering 3/4 of the follicle, and there is RI which is 0.4 PSV. So that is the mature follicle. And if you put a 3D scan, 3D, you will get a nice cumulus cumulus complex or OCC, which can be seen. That means this is follicle which is about to rupture. You can also measure the volume of the follicle, which is normally between 3 to 7 cc. It should be normally dominant follicle should have 3 to 7 cc of volume. So this is what you come to know by Doppler. You see the endometrium, see the anatomy, see the pear-shaped endometrium. You can do the grading of the endometrium, whether it is hypoechoic or hypoechoic, and depending on that, you can come to know whether the endometrium is in the secretory or proliferative phase. And then you could do Applebaum scoring, where you put the blood color Doppler and divide this into 4 zones: zone 1, zone 2, zone 3, and zone 4. Zone 4 is something where vessels are reaching the endometrial cavity, and here you get the best results. So this is something which you do on the day of HCG to know whether the endometrium is receptive or not. So if the endometrium is grade 1 and zone 4, you will get best results. If endometrium is something like that, this where the endometrium is thin and the blood supply is not good, then the miscarriage rate is also very high. Patient will not conceive at all, and if she conceives, there will be a miscarriage. You can put 3D on the endometrium and see the color flow and see the volume of the endometrium. Volume of the endometrium is usually 3 to 7 ml, which is considered as favorable volume. Now, on the day of HCG, so this is something which you see, and then you do the secretory see the corpus luteum and see the endometrium. The endometrium should be highly vascular, and corpus luteum should also be highly vascular, which suggests that the progesterone levels are high, and that means that the conception levels are high. If there is the endometrium is not vascular and the corpus luteum is not vascular, that means there is a luteal phase defect. So this is how you go. Human endocrinology and ultrasound can be correlated with each other. You don't have to do many investigations if you do ultrasound properly. If there is early recruitment of follicles, that means the patient has a case of diminished ovarian reserve, FSH levels are high. If the thickness of the endometrium is very thick on the day 2 of menses, that means the estrogen levels are high and also progesterone levels are high. The stromal flow, if it is high on the day 2, that means the LH levels are high, that means she is a case of PCO. Echogenicity of stroma is more, that means LH levels are high, that means she is a case of PCO. If the andro follicles are more, that means she is having high androgen levels, that means again PCO. And if there is a high uterine artery resistance, that means you require more doses of gonadotropins. So that is how endocrinology can be correlated with ultrasound. And then on pre-HCG scan, if there is a good perifollicular flow, that means E2 levels are high, and good endometrial thickness, that means adequate estrogen receptors are there. If the endometrium is fluffy, that means the exposure to progesterone is early and premature LH surge has taken place, and follicle wall is having increased echogenicity, that means again premature LH surge has taken place. In luteal phase scan, corpus luteum is having high vascularity, endometrium is having high vascularity, that means progesterone levels are good and the chances of conception are more. If the corpus luteum is not having good vascularity, that means there is a luteal phase defect, and low vascularity means inadequate progesterone levels, which means more chance of miscarriage or failure. So all these things can be concluded on ultrasound, and therefore I must say that ultrasound is here to stay and is actually replacing most of the investigations. Now I'll quickly go to the second question. और दूसरा सवाल है कि are day 2 assays losing their significance? What are day 2 assays which we do? Classically, we do FSH, we do E2, some people do LH, and we do antral follicle count. So these are the 4 things which are done on day 2 of menses. Now the advantages of this, they are time tested, they are age old. Since so many years we are doing all these investigations, they are very cheap. But there are some disadvantages of day 2 investigations. One is that they are influenced by external factors. And secondly, the accuracy in prediction is not very good. The accuracy in prediction is less. That is a problem with day 2 test. So since last 5 years, there is a rise of AMH as an investigation and marker for ovarian reserve testing. Change is the only thing which is constant, and this is a change which is for good. And the more and more people are now going for AMH as an investigation of choice for ovarian reserve testing. The AMH levels less than 1.1 is low, 1.1 to 3.5 is normal, and more than 3.5 is high. This is standard levels which we follow in our day-to-day practice. If you look at the intercycle and intracycle fluctuations, you will find that FSH and LH, they are fluctuating throughout the cycles, but AMH is not fluctuating throughout the cycle, and that is the beauty of this AMH. That is the advantage of AMH. You can do it at any time throughout the cycle. Second thing, if you do FSH and LH, you will find that they are influenced by the OC pills, by the GnRH agonists, or by the drugs which the patient has taken in the previous cycle. But in AMH, there is no influence of OC pills, there is no influence of gonadotropins, no influence of GnRH agonist on AMH levels. And that means AMH levels can be done irrespective of whether the patient is taking any treatment in the previous cycle or not. This is a very beautiful and nice diagram, which is a very famous diagram by Lamarca, which says that AMH has got its secretion at the level of primary, secondary, small preantral, and the antral follicles. So AMH has got this much of span of 120 days, while FSH dependence starts at a later stage, and therefore AMH has got its significance. And not only this, AMH will help you in reproductive life planning also, like means how many. It is an age independent marker. You know the AMH levels, you know so many things. Well, if you're planning for pregnancy, whether you should plan early or not. If you're planning for marriage, whether you should plan early or not. So in today's scenario, it is very logical. If you know the AMH levels, you can tell so many things about the patient, whether she is having diminished ovarian reserve, whether she should marry early, what are the chances of conception. So many things you come to know by AMH level. So if you have got a AMH level in your hand, with the and the patient comes to you with AMH level, you can actually work as a part-time palmist and tell her about her भविष्य. आगे क्या होने वाला है, तुमको कितने बच्चे हो सकते हैं, तो आपने कितनी जल्दी शादी करनी चाहिए, ये सब चीज हम लोग AMH के एक लेवल से बता सकते हैं. That is the advantage of AMH. So in IVF also or in ART also, AMH is a novel clinical marker of ovarian reserve response and response to gonadotropin. So if you know the AMH levels, you can decide the dosage of a gonadotropin. You can decide the treatment plan. You can decide whether the agonist cycle is better or antagonist cycle is better. You can decide whether you start with REC FSH or you start with HMG, you add LH. So many things you can decide how much should be the starting dose of gonadotropins and what is the expected response or anticipated response. All these things you come to know from AMH levels. So you get quantitative and qualitative response in ART if you know the AMH levels. And this is a chart, and I feel all the newcomers, especially those who are new in fertility practice, they should take a screenshot of this beautiful chart, which gives you idea about the various ovarian reserve testing markers and their significance. Age, AMH, FSH, and AFC are the four markers. Prediction of poor response. Age is good, AMH is very good, because even in young age the patient can have poor response. FSH is okay, AFC is good. Prediction of hyper response. Here FSH is of no use, but AMH is really good. PCO you can diagnose on AMH levels. You cannot diagnose PCO on FSH levels. Low intracycle variability. This is the beauty of AMH, which is not seen with FSH. You cannot do FSH at any time, and you cannot do FSH if the patient is already on OC pills in the previous cycle. Operator blinded to operator, ultrasound is the problem. If you have a good sonologist, then you get good results. As we have discussed, all these things which we have discussed in sonography, they are possible only if you have a very good man behind the machine. So the man behind the machine is important. Your eyes see what your mind knows. So unless you know, you will not be able to see anything. So you need a good operator, good sonologist to know so many things which are there in fertility practice. And therefore, and as far as cost is concerned, age is the cheapest one, provided the patient tells her correct age. If the patient does not tell her correct age, then age is also of no use. But otherwise, you will find that AMH is one of the best markers of ovarian reserve testing of all the markers which are available in today's scenario. So in conclusion, yes, day 2 hormonal assays are losing its significance. AMH is slowly but surely replacing FSH level assays. FSH and LH estimation will soon be history, and AMH is one of the best markers of ovarian reserve. It does not predict pregnancy, and no one can predict pregnancy, and AMH also does not predict pregnancy, but it is a good marker. अब तीसरा सवाल, I think Pratik, I have 5 minutes. Hello, should I continue?
Yes, sir. If you could please conclude quickly because we need time for the Q&A also.
So shall I conclude in 5 minutes?
Yes, sir. Please. Thank you.
Okay, thank you so much. So तीसरा सवाल है regarding semen analysis. Semen analysis alone is sufficient, or we need to do sperm function test to do in all male partners. So our problem with gynecologists is we ignore male partner, we do not take proper history, and we should have a protocol. We should talk to the patient, take proper history, and take the help of a sonologist, sexologist, urologist, etc. And you should actually follow a protocol. You should go beyond semen analysis, and you should take medical and sexual history, physical examination, ultrasound, endocrinological evaluation, carrier tapping, Y chromosome microdeletion, genetics, sperm function test, testicular biopsy, and post ejaculation urine examination. This is the protocol which we all should follow. And even though we are not doing all these things, we should know all these things, because whenever we are treating a male partner, we should be aware of how to go ahead with the infertility treatment in male partner. The problem is the male factor is on rise and rise and rise. The question is, where have all the cowboys gone? And this is really a serious question, and we all should actually think about this, that why the sperm count is going down and why the problem of male infertility is on rise. It is said that nothing succeeds like normal semen analysis report. If you have if the patient belongs to a elite 100 million club, more than 100 million sperm count, then there is absolutely no problem, and there is no need to do anything except the patient has got performance pressure and performance erectile dysfunction. Then there is a problem. Otherwise, semen analysis good report means कुछ करने की जरूरत नहीं है. But the problem is that semen analysis is done by inexperienced persons, and it is very easy to do this test badly, and that is the problem. Therefore, you must insist on doing the semen analysis from a person who is expert and who is following WHO 2010 criteria for semen analysis. And these criteria are important. We all know this criteria, so I will not go into details of this criteria. But we should know that even this WHO 2010 criteria has got limitations. Some people say that this is not a very good criteria because it is done only from 8 countries. The abstinence period is not good. Only one analysis is performed. Cutoff is 5th percentile, and sperm concentration is not done properly. And therefore, many studies and many special interest groups have come, and they have said there is a estrus special interest group, and this estrus special interest group says that there are many limitations of WHO 2010 classification, and so you should go beyond semen analysis. So this is a paper which says that prediction of male infertility by the WHO laboratory manual for assessment is not good, and it cannot be used to predict fertility unless and except the patient has got azoospermia, necrospermia, or globospermia. These are the conditions where the patient cannot conceive. But otherwise, WHO criteria is not alone is not sufficient. So if alone, it is not sufficient alone, then what you should do? There are many studies which say that you should do something more beyond semen analysis. Some people say that total mortal sperm count is better. Now it is proved beyond doubt that total mortal sperm count is a better indicator for the severity of male factor infertility. And then there are advanced sperm testing. These testing are oxidative stress evaluation, DNA fragmentation test, hypoosmotic swearing test, anti-sperm antibody testing, teratozoospermia index, and CASA. All these tests have got their own significance, and the hypoosmotic swearing test give you idea about the vitality of the sperm. Anti-sperm antibody testing is done whenever you are anticipating some immunological factors, like the patient has got say history of torsion or history of trauma or vasectomy, or the patient has got unexplained infertility or recurrent implantation failure, recurrent pregnancy loss. You should do anti-sperm antibody testing. Sperm DNA fragmentation is becoming more and more popular nowadays, and it is said it is not done routinely in semen analysis, but it is said that it is because of the oxidative damage, stress, or damage to the sperms that the DNA fragmentation of the sperm increases. And with the increase in DNA fragmentation, the problem of infertility is on the rise. And therefore, it is said there are many tests like tunnel test and comet test which are done. It is said that if the sperm DNA fragmentation is less than 15%, you get the best results. If it is 15 to 30%, you get good to fair results. And if it is more than 30%, then you get poor results. There is something called as teratozoospermia index, which is also important for the patient's semen analysis, and there is a CASA which is said to be not very good because it was initially it was very popular, but now accuracy is in doubt because it is expensive machine and it requires good technicians and it does not yield much of the information. Therefore, the grade A evidence says that CASA is not superior to conventional semen analysis. Now the $1 million question is: do sperm function tests improve the efficacy, and it should be done in all the patients? The answer is it should not be done in all the patients because it is expensive, it is complex, and may not affect treatment. So where will you do DNA, sperm DNA fragmentation testing and anti-nuclear antibody testing and other testing of sperm function tests? You will do this in particular situations. Like patient has got recurrent pregnancy loss, patient has got unexplained infertility, the patient has got recurrent implantation failures, the patient has got immunological factors. These are the situations where you should do sperm function test. So yes, the answer is sperm function tests do have the role to play, and especially SFTs are important whenever you have to take the decision of the right choice of treatment. Suppose you are in dilemma, you are on crossroad, whether to go for IUI or to go for ICSI, then you have to take the help of this sperm function test. So again, this is a chart, and I think you all should take the screenshot of this chart as well because it gives you idea about whether various sperm parameters which can be used in the management of the patient or treatment plan of the patient. Sperm concentration more than 10 million IUI, less than 1 million ICSI. Total motor sperm count more than 5 million IUI, 1 to 5 million IVF, less than 1 million ICSI. 24-hour sperm survival more than 70% IUI, less than 70% ICSI. TZI less than 1.6 IUI, more than 1.8 for ICSI. Hypoosmotic swelling test more than 58% or 60% IUI, more less than 50% ICSI. And the most important DNA fragmentation index more than 30% ICSI, more than 60% TESA ICSI, less than 15% IUI. So you can take the decision depending on the parameters how to go ahead in the treatment plan. So that is the beauty and that is the best part of the sperm function test. So I'll sum up my topic or talk with the ACOG, ASRM, and other recommendations regarding the best fertility practices and how to go ahead with the infertility workup. Infertility evaluation to any patient who has more than 12 months of infertility should be done. If the age is more than 35, you should start evaluation within 6 months. If age is more than 40 years, then you should do immediate evaluation. Condition known to cause infertility, you should do immediate evaluation. You should take a history first, do physical examination and ultrasound, and then only you should go for ovarian reserve testing, ovulation function test, and structural abnormality testing. So you first do three things and then do other things. That is how you should go. Get proper history and semen analysis of a male partner from a proper person according to WHO 2010 criteria. Take help of andrologist in male factor SOS whenever required. Some other recommendations: do pre-pregnancy counseling in all women. That is what I have already told you. You take this period, take the advantage of this period and do pre-pregnancy counseling. In view of fast ovarian aging in Indian women, do start investigations after 6 months of married life if the age is more than 32 years. In India, thyroid testing is recommended in all patients because of the high incidence of thyroid disorders in India. Check mid-luteal progesterone levels to assess ovulation, but this is grade 4 evidence, grade C level 4 evidence, and use ultrasound, which is grade B evidence. So ultrasound is, I think, better than progesterone levels. Endometrial biopsy should not be done unless and until you are suspecting malignancy or you are suspecting infections. Do ORT if more than 32 years at risk, and if less than 32 years, you should do if there is risk of infertility. Do ORT in all patients of IVF to predict the response. Do HSG first for tubal patency. Laparoscopy is not routinely recommended. Laparoscopy is done only in cases of tubal block, endometriosis, or PID, and do not do hysteroscopy unless and until it is indicated. So only indicated you do hysteroscopy. Again, semen analysis from a proper person. That is something which we all should remember. So to sum up, friends, to make a difference in someone's life, you don't have to be brilliant, rich, beautiful, or perfect. You just have to care. So in infertility practice, you should remember, don't quit Just do it, and ultimately you get results. So I thank you all for patient listening. Thank you very much. Thank you, Pratik, for giving me this opportunity. Thank you, Amox.
Thank you, Dr. Chaitanya, sir. I think
Actually,
it was, yeah. Yeah, Chamila, please.
yeah, thank you, Dr. Pardeshi sir and Dr. Pratik Tambe for giving this chance to listen to great talks. It was like listening to an oration from both of them, and so comprehensive, but you made it so simple. Could see the passion which you bring it almost like you were teaching a class. It was wonderful to listen to that. And actually, we have done one multicentric trial on ovarian reserve in India. We did from 10 centers throughout India from all the zones of the country. And it was a very simple study. We just wanted to find out what were the factors which was affecting the ovarian reserve in Indian women. And what you said was the answer. Like, age of the lady is much younger in in an Indian population. The years of infertility matters in Indian population. And we found out that diet, your ethnicity, nothing matters, but age and years of infertility is the one which matters in Indian population. And that will come for publication in a month. Actually, we did it from all the zones of the country. We had Dr. Sonia Malik, Dr. Asha Bakshi, and from East Zone we had the IAH also there. So you will get it soon. And it was wonderful listening to you. Thank you so much.
Thank you,
Thank you,
Dr.
Pratik,
Thank
for the
you.
opportunity. Thank you.
Thank you so much, Dr. Chaitanya. I think it was an excellent deliberation. And you just
Thank you.
so nicely you brought out the points, like where we need to intervene and where we just need to counsel. She is not aware, but she is a high risk and we need to wake her up. So that was very nice. And the other thing was the targeted approach, the 5 points that you brought up. Women more than 35, expedite your evaluation. More than 40, just do imaging. Comprehensive medical history, targeted physical, and test has to be focused. And the 5 points, the ovaries, tubes, and the uterus, and of course the dysfunction and the semen analysis. So that was really, really wonderful. And the do's and don'ts. And it really brought us to an overview, really sitting and just doing in action. So it was really wonderful listening to
Thank
you,
you, Dr.
sir.
Ritu. Thank you, Dr.
And
Ritu.
I think, Dr. Pratik, I could take up some questions and queries from the audience.
Yeah, there are some
And
audience
Dr.
questions for the first
Kiran,
speaker. Yeah, please go ahead.
yeah. And I think both the speakers were really fantastic. So Dr. Kiran Sonwalkar asked that what possibility of mother and father RH negative and the baby born with positive blood group and vice versa?
Of course, there is possibility of extramarital affair, and one thing is about DU positive, which is weak positive, and it can cause immunization or sensitization of the mother. So it is possible.
Okay, thank you, sir. And ABO incompatibility and the role of anti-D.
Immune, pardon?
I think this has already been brought out. I'll go to the next question. Many patients avoid taking anti-D despite indication or prescription due to low socioeconomic conditions, and how do we deal with it?
There is proposal of collaboration between government and NGOs. Even the companies like BSV are providing anti-D to the government centers, and we can avail anti-D from that centers.
Right, sir. And is it rational to do IDCT in positive blood group mothers too?
Yes, ICT should be done in all cases at the first visit is one recommendation. Though it is very, very rare to find it positive in RH positive mothers, but there are some uncommon blood groups which we are not testing routinely. So ICT should be done at first visit. It is the most simple test, very cost effective test, which is very low cost test. And if offered, we can minimize the HDFN in the newborns.
Right. Thank you, sir. And if facility for fetal-maternal hemorrhage is not available, we presume more loss than normal. Can we increase the dose of anti-D? And I think that you've highlighted very well. And is flow cytometry available in India?
It is available at some centers in Mumbai, but I don't know about other centers.
Right. So if there's a patient who's gravida 3, which RH negative and not taken NTD any of the pregnancies, she's come to us at 20 weeks at the first visit and the ICT was negative, do we give the anti-D there itself or do another at 28 weeks?
She is very fortunate to have ICT negative, and she is the most ideal candidate for anti-D prophylaxis. We should offer her anti-D prophylaxis, but it should be given at 28 weeks by repeating the ICT test at 28 weeks.
Right. Thank you so much, sir. And if Dr. Chaitanya, if there is a persistent cyst of 18 millimeters, it's persisting since the last 3 months and on a day 2 scan, then how do we proceed? Do we still wait or any other option
Yes, the
for an
most important thing
ovulation
is,
induction?
yeah, the most important thing is, I think, to see whether it is functional cyst or not. So put a Doppler flow, and you can try a couple of cycles of OC pills. And I feel that if it is persistent, if it is small cyst, then you can go ahead with ovulation induction.
Yeah, I think less than 2 centimeters, we could
You
still
can go ahead.
consider it, sir. And you said FSH and AMH, yes, a beautiful comparison in them. And but should we really go in for FSH or not at all?
Frankly speaking, we have stopped doing FSH, but still many people they do it because there are the still the FSH is considered as gold standard. In fact, if you look at the SRA guidelines of premature ovarian insufficiency, they have categorically said that FSH more than 25 is POI, but they have not mentioned about AMH. So and the problem with AMH is still is not accepted because of the cost factors, and AMH is becoming more and more reliable. But still, and I have seen many. In fact, we did a telephonic survey last year with all gynecologists around in and around Nagpur, and we found that there are still many gynecologists who do both FSH and AMH both, just to confirm and reassure that the AMH levels are giving the correct diagnosis. And of course, AFC is always there.
And if there's a patient and has got 3 semen sample reports with him as azoospermia, and the FSH and testosterone was done, testosterone was normal, and the FSH was 11.8, do we now counsel that he can go for a testicular biopsy or not, seeing to the FSH levels?
We should. In fact, if it is less than double of normal, we should go for testicular biopsy. So testosterone. So we, in fact, to be very frank, the testicular biopsy is something where people don't know. Many people don't know that testicular biopsy is something which should be done with the facility of cryopreservation for the sperms. Because if you do testicular biopsy, you get the report and you are damaging the testes and doing the fibrosis to the testes, and which is may have its impact on in future treatment. So whenever you do testicular biopsy in a patient, you should have a facility for cryopreservation, or else if it is really not required, you should avoid testicular biopsy and straight away go for testicular sperm extraction and go for IVF.
And something as sporadic, I think spermatogenesis also.
Yes, it is always there.
Consideration. Yeah. And so if there's another patient who's got 4 IUIs done, and now we want to go in for an IVF because of the failed 4 cycles, and should we advise, has got a semen count of 110 million and 50% motility, actively motile, should we advise a DNA fragmentation test before going for an IVF?
In fact, this is the patient where DNA fragmentation has got a role to play, because the patient has got normal semen analysis report and still the patient is not is having IUI failures. So you need to go beyond semen analysis, and this is the situation where you should do DNA fragmentation testing. And DNA fragmentation test not only gives you idea about, suppose the DNA fragmentation is very high, you can actually go for testicular sperm extraction where the sperms are not crossing epididymis. The damage, oxidative damage is less, and you get better quality sperms. The abstinence should be low. That is one more thing. And the second thing is testicular sperm extraction, which is going to give us good sperms, good quality sperms.
So I think if there are no more of questions, Dr. Pratik, both the speakers really fantastic deliberations, we must say, and it was a treat, listening to both of them. So thank you so much, and also my co-chairpersons also for the same.
Thank you very much to all the stalwarts who are present today, despite it being a holiday. Since there are no more audience questions, there are 1 or 2 comments from the audience. I think Dr. Kiran Sinha from Kanpur has logged in, and she said excellent deliberations and two fantastic talks, especially Chaitanya. She's given you a lot of appreciation. So thank you, ma'am, for logging in. And it's wonderful to know that though this is an AMOX platform, we've managed.
I think some problem with some net problem with Pratik, it seems.
I'm sorry for the interruption. There's some network issue with Dr. Pratik. You can just bear for another 2 minutes.
Yes, Pratik.
I think the glitch in the internet, so apologies for that. It's my proud privilege to present the official vote of thanks. Thank you to our esteemed President, Dr. Nandita Palchetkar, Secretary, Dr. Arun Nayak, three amazing chairpersons, Dr. Rajendra Singh Pardeshi, our Vice President, Dr. Charmila from the South, Dr. Ritu Khanna from the East. Wonderful comments and insight into both the talks for today. Thank you very much to our two esteemed speakers, Dr. Sagar Kataria, Zonal Coordinator of AMOGS, and Dr. Chaitanya Shembekar, my co-chairperson, chair for the Infertility Committee of AMOGS. Thank you so much for your wonderful talks. I would also like to present my gratitude to the ICOG chairperson, Dr. Mandakini Megh, the secretary of ICOG, Dr. Parag Bidiwale, for granting us the ICOG credit point, to Science Integra for their wonderful academic support, always there in the background. Subbu, Shrimon, Session, thank you so much for all your help. Our academic partners for today, Bharat Serums and Vaccines, the Feminora division, and the Bridging Bharat initiative, through which we have done this entire series of events over the past 1 year. We hope to see all of you very soon. We had an audience of nearly 400 which had logged in today. And thank you so much, audience, for being here. We hope to see all of you very soon at the next event. Thank you so much. Goodbye. God bless. Stay safe.
Thank you, Dr. Pratik.
Thank
Thank
you.
you, Dr.
Thank you, Pratik.
Chaitanya and Dr. Sagar, Dr.
Thank you,
Chamila and
Pratik.
Dr. Padesi, sir. Thank you so much.
Thank you so
Thank
much.
you.
Bye bye.
Thank you, everyone. It was nice
Science
opportunity.
Integra also.